Hello, my name is Per Carlbring. I'm a professor in psychology at Stockholm University. And as you can see here, there is not only a logotype for Stockholm University, but also for Seoul Cyber University. And why is that? It is because we have a nice collaboration between Stockholm University and Seoul Cyber University. And I actually been invited twice. So here is the first time in 2017 talking about, yes, you guessed it, virtual reality. And again, 2 years later, talking about virtual reality and technology supported therapies for anxiety disorders and other problems like depression. So today I'm going to talk about virtual reality. And virtual reality is something I guess you've already perhaps tried. In the old days, you had 3 degrees of freedom. So you can see that you could use you could turn your head at 3 different directions. So it could be this way, it could be that way, and it could be that way as well. So that's 3 degrees of freedom. But now, since a few years back, you've started to do 6 degrees of freedom. So you can actually, you don't have to be stationary, sitting in a chair, enjoying or working with virtual reality. So now it's 6 degrees of freedom. And here's a short video of what that actually means. So you can see me not sitting in a chair, but actually walking. And this is a special kind of place where you can walk around freely. And this is, of course, really good if you want to do things in virtual reality, like moving into spaces that are crowded, or if you have problems with claustrophobia, for example. So this is just to show you that nowadays we're talking about 6 degrees of freedom of virtual reality. And when I'm saying virtual reality, there is actually many. So virtual reality is what we used to be talking about. Here is a study that I've made or been the investigator of, where we talked about virtual reality, but also mixed reality. So that could be either virtual reality, where you make everything in the virtual reality, you can have full control of that, but you also have a true virtual environment. While you can also use augmented reality, which is more of using some portions of the real world and then adding things to it. So you put sort of like virtual reality into the real reality. And this nowadays is perhaps more often referred to as mixed realities. But I'll be talking about virtual reality because that's what I'm used to, but you could think about mixed realities. So this has been around for quite a long time. This is me in the 1990s. So you can see it's rather bulky, but this was a real virtual reality equipment. And the graphics were really, really bad. So it started in sort of the new generation started in 1990, and it's not until recently where we've seen less bulky things, so you can use this for more of like commercial consumer products. And early on it caught on, and scientists wanted to do treatment studies on, for example, anxiety disorders. And this is what it looked like a few years back now. So this is trying to treat animal phobia. And this is a nice example from 1997, where you had claustrophobia treatment. So, and the good thing about virtual reality is that you can actually customize what you want. You can individually customize what the environment is going to look like. So here you can see that the wall is coming closer, so the room is getting smaller and smaller in order for you to get the sense of being in a smaller room and exposing yourself, which is the current treatment. So in small steps, you're facing your fear. So these are things that were not too many years ago. And actually, this has been around for quite a while. So this is the Sensorama. It was a machine that was the earliest known examples of immersive multisensory technology. And this technology was introduced in 1962. So quite a long time ago. And since then, you can see that the resolution or the graphics has improved rather rapidly. For every year, there's a big leap in how good and how authentic different things look. And also the field of view. So in the beginning, you could only see your like a few degrees straight forward, like a tunnel. But then gradually, as the years progressed, you could see more and more and almost 180 degrees. So looking at the examples of treatments. So this, as I said, was something that was developed into treatments by people in Canada and in Europe as well. And you can see these are the earlier studies where you try to treat flying phobia and specific spider phobia and other kinds of specific animal phobias. And you can see here when you compare people having had the treatment versus the ones that didn't, you can see that the effect sizes, that the effect of the treatment was rather good. So it's better to get treatment than getting no treatment. But that could, of course, be explained away by the fact that people spontaneously remit and the passage of time could heal you. So here's another one, looking at if you were randomized to either virtual reality or to something else, which usually was a waitlist or an active placebo. What happens then? And then you can see that it seems like if you have an active treatment comparison, it seems like there is no difference of both treatments. Both groups are getting rather good outcomes. So this is in 2015. And then we did a new study published in Journal Anxiety Disorders, where we looked at all the studies that were available. And we looked at a lot of abstracts, and then eventually we included 30 randomized controlled trials or 30 high quality treatment studies. And looking at those, we could see that this is, of course, hard to see, but it's you can see that it's a lot of people, or a lot of research having been done in the early 2000, but also in the later 2000, let's see, 2017, for example. And if you compare virtual reality exposure therapy versus a control condition, then you have a good outcome. It's better to get virtual reality treatment than getting a control condition, which could often be a wait list. And so that's a good thing. It's better to get virtual reality for regardless of what kind of problem it is, at least on a group level. And then we also looked at if there is a difference between whether you get virtual reality treatment for like anxiety versus getting a real face-to-face treatment. And here you can see that there's almost no difference between the two. So it seems like, at least from these studies, that if you wanted to participate in a treatment study, it doesn't seem to matter whether or not you get virtual reality or you get real face-to-face therapy for these kinds of problems. But of course, there are some methodological problems with these studies. And we could also see actually that if you have a study with a large sample, a lot of participants, then usually the effect is smaller. And that's almost always the case when you look at treatment studies. The more well-controlled, the more methodologically sound treatment studies that you're looking at, and the more participants they have, the lower the effect tend to be. But still, there is a nice effect of getting virtual reality treatment. But it's not always happy-go-lucky. Sometimes you have problems getting treatment. And this is not specifically related to virtual reality, but here you can see that we've looked at negative effects of psychotherapy. And usually you can see, regardless of what kind of therapy you're doing, you can see that there is usually about the 5 to 15% of the participants, of the patients, that actually deteriorate during the time of the treatment. So you don't get better, and you don't even stay the same, but actually you do get worse. So that's interesting to know that regardless of what kind of treatment it is, whether or not it's virtual reality or face-to-face treatment, people are not vaccinated against feeling worse. So that's a good thing to know. Not a good thing that it's happening, but a good thing to know that about 5 to 15% deteriorate. And we wanted to look at deterioration rates in virtual reality in this study. So this is a rather big study where we got data from a lot of different virtual reality studies. And what we could see was that participants are less probable to deteriorate in virtual reality and other active treatments than being in a waiting list group. So it doesn't seem to be, it seems like virtual reality on a group level seems to have rather good effects, and also is not a treatment that lends itself to a lot of deterioration. So that's a good thing. So in this study, we looked at 15 studies and 810 people, and we could see that the deterioration rate, the proportion of people getting worse during treatment was 4% if they got virtual reality, versus if you were in a wait list control, it was 15%. So what do I think about virtual reality? I think virtual reality can be used in two ways. One is, and I'll give you examples of this soon. One could be that you get virtual reality and you treat yourself, so self-help for the individual patient on the one hand, and then on the other hand, it could be virtual reality being used within a setting of therapy, so in session, face-to-face, but the therapist is using virtual reality in the face-to-face session, or it could be a mix, of course. So the good thing is about virtual reality is that you can easily customize the stimuli. If you want to do an exposure, then you can if you want to do an exposure of an object, for example, or a setting, then you can gradually change this in good ways, which is not possible without virtual reality. And you can also do overexposure, which has been found to be a good thing. So if you're afraid of spiders, normally, if you are really lucky in your treatment, then you can have the patient having multiple spiders in the hair, and that's overexposure. That's more than you're supposed to be able to deal with. And with this, with virtual reality, you can also do overexposure. So for example, I'm not saying that this is a good thing, but just an example of overexposure. If you have a fear of heights, then you can actually treat the person, and at the end, you could ask the patient to walk on a plank and then jump off into an abyss. That's not something you should do in real life, but something you could do. I'm not saying it's a good thing, but it's just an example of overexposure, things you can do that would be impossible or unethical or lethal in the real world. And you can also change your body. So for example, if you have problems with anorexia or some other body problem, then you can change the appearance of your body in different ways. You can also interfere with the memory reconciliation by showing a spider that you normally would think would be threatening, but then instead of doing something threatening, it instantaneously starts to dance or doing something goofy. And I'm writing rescripting here, which I'll come back to. What is rescripting? I'll tell you soon. So what do therapists say, or counselors and psychologists? We asked them, and what we could find was that therapists had an overall positive attitude towards virtual reality, and they were interested in using this in their own practice. So this is me in the woods, sort of mixed reality, perhaps. So we wanted to do a study called VIMSI. which is a Swedish name for a song about the spider. So this is a few years back now, and we wanted to see if people reacted differently to different stimuli. So we wanted to see if people reacted differently to a spider versus a ball. And so we copied, and this is the research room that we have at Stockholm University, and we copied that into a virtual room to see whether or not people reacted differently. And this is a short video that, let's see if I can start it. Yep. So here you can see that this is just a study where we wanted to measure whether or not people were sweating and if they reacted differently to different stimuli. And so this is not a treatment. This is just a way of showing that you can customize everything. So wherever this girl looked, there was a spider. And what we could see was that people did react differently. They were sweating more when they saw an object that was a spider versus a ball that was just rolling around. You can see the spider falling down from the roof onto the desk. So this is something that made us happy and convinced that maybe we could do a treatment that could be compared to the best kind of treatment that there is. So this is a person that has come up with a one-session treatment. So you can treat virtually almost any specific phobia with only one exposure. So you only meet the person once during 3 hours, and then you gradually expose the person for the stimuli, and then you get really good results, actually. So this is the guy that invented this, called Lars Jørn Øst. Before we started doing this, we asked people to fill out questionnaires, and also we asked them to go into a room, and we said, inside the room, there is a spider. Go into the room, and if you dare to, take off the lid of the box where the spider is, and then hold it for 20 seconds. Then you would get maximum points, which would be 12. And then we randomize people to either virtual reality treatment or real therapy with a real therapist and real spiders. So the total treatment time was 3 hours. And the game that they played in virtual reality, the ones that were randomized to virtual reality, was called ITZY. And the idea was that you observe things in VR, then there is a game-like thing, and then there is a challenge. And all the time you had a virtual therapist providing dynamic support. So if you're afraid, it gave you more support, and if you were not afraid, then it gave you other information. And of course, it was also gradual. So you started off with a sort of like a Disney-looking spider, something that's not threatening. And then you were supposed to look at the spider, and then the points would increase up to 15,000. And if you looked away, then the points would gradually go down. So that was a way of building into the system that you actually were paying attention to what you were afraid of. So this is a gradual difference between the spiders. You can see that they progressively get more and more realistic. Sometimes the program stopped and asked for your subjective units of distress. So how much anxiety did you experience at that time? And this is a good way for doing research and getting numbers of how afraid are you. And also this could be interpreted by the program. So if you were really afraid, then the program would customize the exposure. Of course, it would have been nicer not having to ask the person, but instead of using like how much you're sweating or your pulse, for example. But that's not what we used. And you can see that they progressively get more and more realistic. So this is an end game, sort of like a boss stage. There were 10 different or 9 different mini games: introduction, glass escape, garden dash, rain rescue, water cross, food fiesta, memory, baby save, hygiene help. And now you'll see a 1-minute video of what this looked like. So, or do we see that? Yeah. No. Didn't really work. That was too bad. Well, maybe I can link this instead. So people looked at this video, or people play this this game for. Oh yeah, now you can see it. People played this game for up to 3 hours, and that was the only treatment they got. Here you can see that you're supposed to help the spider. The spider was trapped under a glass. So everything is about helping the spider. Someone is throwing balls at the spider, and your task is to protect the spider with this cushion. Now the program asks how much anxiety you feel. And acid rain is coming down on the spider, and you're supposed to hold the umbrella. So you're always trying to help the spider. Now the spider is hungry, and your task is to feed the spider 15 times. And progressively, the spider is getting more and more realistic. And this would, of course, be challenging if you have spider phobia. Now the spider has lost her children, and you're supposed to turn the children to the mother's back. Now the spider has hygiene problems, and you're supposed to get rid of the spots. So everything is about helping the spider. And what we could see after being randomizing people. So, of course, what kind of equipment did we use? We used a Samsung rather than an iPhone. So you could use this on your own phone. And this is the level of technology that we use. So it wasn't a really expensive equipment, and anyone can use this. So looking at this, how afraid were you of the spider before you started treatment? Did you dare to go into the room and take the lid off the spider and hold it for 10, 20 seconds? No, you were not supposed to be able to do that. And you can see that both the one-session treatment and virtual reality started off having real problems with spiders. Almost not going like 4 meters away from the spider. And now you can see that the people that were randomized to getting one session of virtual reality, playing this game, improved really well. The within group effect size was 1.35. But of course, the real therapy with the real spider and the real therapist was a little bit better. But I was surprised that this was actually so effective. And we can also see that when we follow these people up for 3 months and 12 months, you can see that the success that you've gotten within the 3 hours of treatment actually was maintained when we did follow up. So that was a good thing. You only play the game once, or you got face-to-face therapy once, and these are the results for 100 people that were randomized to either one or the other of the treatments. So this is a study that has been published in Behavioral Research and Therapy. And as you can see, that was more of cartoonish looking spiders. We've done another study where we used 360 video. So instead of having these cartoon ones, we used the real spiders. And in this study, we could also see that people improved quite a lot, and improved more than being in a waiting list, which was looking at the documentary. So that seems to be also effective. I'm not sure what's the most effective, and the jury is still out on that thing. But I think the next thing will be not 360 video, but something that's called volumetric 3D video, where you can see this person and there is a lot of cameras everywhere around this person. So that makes it really realistic, and also makes you, instead of being locked into a 3 degrees of freedom, it would be 6 degrees of freedom. So this is something I think will happen in the future. Because nowadays, at the time, it's really expensive to do this volumetric 3D. We've done other studies as well. This is for height phobia. where you used, again, just your phone, and got really good results published in JAMA Psychiatry. And this is something that was sent to people, so they treated themselves at their own home and not meeting a therapist, which was kind of interesting. So I think this is perhaps the way to go, or at least it makes it more fun, because this JAMA Psychiatry height phobia treatment was more, again, also like a game. So I think gamification could be a really good thing to go get into. And finally, I'll be speaking about speech anxiety, where we've done studies as well. So 25% of the people in the world think that speaking in front of an audience is really anxiety provoking. And I will show you not this quote, which is kind of fun, but instead I will show you what we did. So it was, again, only a one-session treatment. So you came to Stockholm University for one session, but the session was 3 hours, so quite a long session. And following those 3 hours, you would then continue on your own using a program on the internet for 4 weeks. So again, we used the Samsung, where we, instead of having the therapist and instead of having the patient doing this all on your own, like a self-help program, we had the therapist and the patient and the VR equipment in the same room at the same time. So we wanted to have the person practice different speech tasks in front of an audience. And the audience was, we'd done 2 different studies. One was virtual speech, which is a program that's generates different kind of settings. And the other one is speaking plays. So in the speaking plays study, and they were quite alike, you met the therapist, and the therapist said, now it's time to do a speech task. What do you think about it? Now it's time to do the speech task, but before we start, what do you think? What are your what thoughts are running through your mind before we do this? How do you think you'll come across? And then you talk about that, and then you, as a patient, put on the head goggles, and then you do a speech task, and those, of course, gets progressively harder, but they only last for about 1 minute. So you talk for a minute in front of an audience. It could be this kind of audience. Once you've done that, you take off the goggles and you talk to your therapist about what thoughts went through your mind and blah, blah, blah. And then the therapist says, well, how do you think you came across? And then you talk about that. And then the therapist says, well, let's see. And then you put on the goggles again, but instead of being in front of the audience, you're now transported into the audience. So you can see yourself, because you've had these head goggles and also the hand controllers, and that's been recording how you moved and also recording what you said. So you'll be seeing yourself, of course, as an avatar, not yourself, but an avatar moving the same in the same patterns as you did, and saying the same things and almost lip synced perfectly. And then you look at yourself from the audience for about a minute, and then you take off the goggles, and then you talk to your therapist. So what did you think you were going to see, and what did you see, and what are your reflections about that? And then you continue, and we have a lot of different speech tasks. Here are some examples. And the idea is that you progressively get better and better, and you get feedback from the audience perspective, but you see yourself. So the idea is getting you to become a really good speaker, and at least being able to speak without having this being trapped by anxiety. So we randomize people to either being in a waiting list or to get treatment. And here you can see the 1-session treatment was really effective compared to the wait list. The effect size was good, high. And then following this 1-session treatment, you get 4 weeks of maintenance promoting in vivo exposure. So you were supposed to do things on your own in your real world without the virtual reality. And following those 3 4 weeks, you could see that the people in the wait list did not improve, while the people in the treatment group actually continued to improve. So this was a really effective way of using virtual reality, not only using it as a standalone thing, but helping the therapist become even more effective using VR within the session. And this has also been published. And a final thing that I'll say is that we've tried to see whether or not there are differences in A, B, and C here. You can see that A would be speaking in front of an audience that looks more like a cartoon, and B would be more realistically, but still like something that's been generated in the computer, versus C, which is in fact the 360 video. And D would be speaking in front of an audience without looking at anything. And what we could see was that there seemed to be no difference between A, B, and C. So speaking in front of an audience that looks like a cartoon doesn't seem to matter as one would think, even though it's not realistic. So it seems like doing things in VR can transfer into real world behavior, and it doesn't have to be as believable as the real deal. So that was my last slide, and in a future talk I could talk about what I think will happen in the future, except for the volumetric 3D. But this is a short talk, so I will stop now, and thank you for listening.